Coming up on NPT Reports, Aging Matters, Hospitals and Health Risks.
Nobody is jubilant about going in to having surgery. I've thought about complications and this kind of thing.
We've all had the experience of our proverbial Aunt Mary who comes into the hospital, everything seems to be better, but she goes home and she's not walking or talking the same.
You go to the hospital to be healed, but for older patients, a stay in the hospital can be more dangerous than the condition that brought them there.
About a third of older adults will lose function in the hospital in the traditional hospital model.
How do you feel you're doing?
Not as well as I would like to be.
Falls are increased, the possibility of adverse reactions to multiple medications.
And our patients become confused or altered. They may have hallucinations.
I see she's had a major functional decline. Has anybody seen her yet this morning?
They have seen her this morning.
Just help me feel better.
Okay, we can do that.
Every patient wants to go home. Every patient is deathly afraid they're going to get sent to a nursing home. How can we focus on getting you home? What are the things that we need to do?
That question is more pressing as baby boomers are an ever-increasing clientele for hospitals.
If we can set standards that help show how should we be treating our older adult patients and then help other hospitals implement them, I think that's what we all want.
I want them to have patience and kindness to help me with whatever my needs are, which are going to be different than if you have children in here or teenagers or even just middle-aged people.
Major funding for NPT Reports, Aging Matters is provided by the West End Home Foundation, enriching the lives of older adults through grant-making, advocacy, and community collaboration. The HCA Foundation, on behalf of TriStar Health. The Jeanette Travis Foundation, dedicated to improving the health and well-being of the Middle Tennessee community. Cigna Health Spring. Additional funding provided by Jackson National Life Insurance Company, the Community Foundation of Middle Tennessee, and by members of NPT. Thank you.
If you're sick or hurt enough to go to the hospital, you expect to leave in better shape than when you arrived. But as we age, it becomes increasingly dangerous to be in the hospital. Studies show about 1/3 of patients over age 70 and half over age 85 leave the hospital more disabled than when they arrived. The rules and routines of hospital care just don't work the same for seniors as they do for younger patients. Too much bed rest, over-medication, excessive testing, and poor nutrition can all take a toll on our aging bodies. Hi, I'm Kathy Matea. How hospitals will treat aging baby boomers is a pressing problem. Many are not prepared to meet the unique needs of this growing population. What are the benefits and risks of hospital treatment as we grow older? Are hospital workers prepared to care for older patients? What are hospitals doing to improve outcomes for an aging population? Join me for this edition of Aging Matters as we look at hospital care and what we need to know before entering and leaving the hospital.
Come on, Kylie. Atta girl. Do you notice that when she walks, she is ahead of me, but she turns around and looks to see if I'm coming? That's a girl. She didn't used to do that. We just walked. And so that she knows something is different. Right now, I have a cloth brace on it, and this helps when I bend the knee that it doesn't hurt as much. Okay, let's go, dear.
Dorothy Busick is 2 weeks away from getting rid of her bad knee.
Morning, how are you?
I'm fine, thank you.
She's having surgery to replace it.
Being 95, I've had a few parts wear out.
Family member come back to see you just briefly.
Oh, that's nice. Both of my hips have been done and my right knee. So I figure if I have this one done now, that I'm going to be bionic. And I don't know what else that can be replaced.
Clearly, Busick is not afraid of surgery, but she delayed this knee replacement until the pain was unbearable. thinking her age might make it impractical. That was 3 years ago.
I was beginning to feel uncomfortable. I could see that if I didn't do something, that I might just absolutely end up in a wheelchair, and I didn't want that. And I thought, gee, I bet I've waited too long because I'm getting older.
We ready to go?
Yes, sir.
At the time, she said, well, I'm already 92. She said, I probably won't live that much longer, so she didn't want to bill Medicare for a knee that she wasn't going to get that much use out of. I told her, I said, look, you know, you're to the point now where you can't walk, so it's either be committed to being in a wheelchair or get your knee fixed. Those are your choices.
Okay, Y-E-S.
I do have a choice. I don't have to have this done. I could continue living like this, but I'm an active person, and I still feel that I have some activities that I want to do and some places I want to go.
Thank you.
Any questions?
Those factors were even more important than Busick's age, according to her surgeon, Dr. William Schell, Jr. of Tennessee Orthopedic Alliance.
So it's a very individual decision, but age alone is not necessarily a significant factor in us deciding to do these type procedures. In her situation, we're just trying to improve the quality of life and get her functioning at a better level and make her happy. Sure, if we had a crystal ball, we would know what to do in every case.
The fact is, about 1/3 of patients over 70 years old and more than half of patients over 85 leave the hospital more disabled than when they arrived. Hospitals can be dangerous to older patients, according to doctors who specialize in geriatric care and research.
We've all had the experience of our proverbial Aunt Mary who comes into the hospital, with pneumonia or a urinary tract infection. We give her the right antibiotics, everything seems to be better, the pneumonia is better, but she goes home and she's not walking or talking the same, and may never walk or talk the same, may get confused, or may just take a lot more work from her family to recover slowly. A lot of the time, that's probably the unintended consequence of how we do things in the hospital.
One of the principles of geriatrics is that we try to avoid hospitalization if at all possible. We know that there are many benefits of being in the hospital. Some conditions require hospital care. But if we can avoid the hospital, we avoid complications. It's estimated that up to 50% of older individuals who enter the hospital have some iatrogenic medication or doctor-caused complication. Iatrogenic means that the doctor ordered or the hospital caused something. Now, that's not because of an error, but standard care.
For example, getting a medication to treat one condition that unintentionally causes kidney damage or some adverse effect, accidental falls, infections, pressure ulcers, and complications related to surgery. All contribute to what's known as hospital-associated disability. At some point during a hospital stay, often without clear cause, some older patients lose physical or mental ability.
The older you get, the higher your risk is for declining during hospitalization. And some of that is probably just because you've lost more of your bounce.
I tripped on a rug and fell to where you're standing with my head against those steps. I'm still receiving therapy for that, even though that was in May.
A terrible fall sent 85-year-old Louis Wilhite to the hospital for the first time in his life. The road to recovery has been bumpy.
It started in May with a broken shoulder, and then it proceeded to June when I had pneumonia, and the day I was discharged from the hospital, I had a pancreatic attack. So those were my 3 episodes that demanded emergency care. Getting up out of a chair is not as easy as it used to be. I feel confined. I think that's the main problem.
Wilhite's story is typical for older adults who experience a fall. a slippery slope into declining health.
That's a pretty devastating injury for old people in terms of just mortality as well as how well they regain function afterwards. As we get older and your bones are thinner, you have osteoporosis, fall and break a hip, it's a pretty serious problem with a pretty significant one-year mortality rate.
Why is a typical hospital stay more risky for older adults, even if they're being treated for conditions that also affect younger patients?
Take a group of patients who are, say, 30 to 50. Physiologically, for the most part, they look pretty much the same. Their kidneys are still functioning, their hearts are still functioning, their brains are still functioning, they can walk without difficulty. If you take the same number of patients who are, say, age 70 to 90, there's going to be a vast variety in their kidney function, in their heart function, in their brain functioning, in their mobility.
We got a roof for the Cardinals.
Next year's going to be better.
Dr. Kelly Flood is the Geriatric Quality Officer for University of Alabama Hospital in Birmingham, a leader in age-friendly healthcare practices.
So it could be that as we've aged, we have picked up illnesses such as heart disease or hypertension. Some of us will develop cognitive impairments and dementia, and some won't. Some of us did exercise more than others, so we've built up a little reserve capacity. Some of us have better heart health.
Age really is just a number when it comes to many healthcare decisions for older patients.
It's really more how are they aging physiologically. If I'm 72 and I'm still running 5Ks, then I'll tolerate a pneumonia better than if I'm 55 and I'm bedridden from a stroke.
If you're talking to me, always be on the right, on the left side.
Even at 95, Dorothy Busick's physiology makes her a good candidate for knee surgery.
It's my job to sort out symptoms and decide if somebody really should or needs the operation. She's had a pretty thorough evaluation before we did this. We have a preoperative medical clinic and she's been looked at very carefully.
With minutes before surgery, the medical team at St. Thomas West Hospital checks Busick for any detail that might create trouble, including how to manage her hearing loss.
The anesthesia team has decided that they're going to let you keep your hearing aids in because we need you to be able to hear what they're asking you to do. They'll ask you to wiggle your feet when they're waking you up and just follow some basic commands.
Well, I appreciate all the people that are going to be dealing with me for different things have come in to explain exactly what's going to happen.
You'll just stay exactly how you are, but I'm going to rest you back.
I've thought about those things. I've thought about dying. I've thought about complications and this kind of thing. But what good will it do me to dwell on it?
Just let me know if you need me to go slower.
I'm at the point now where I didn't think I'd live this long. So I'm just delighted that I'm here and that I can have the technology today. Fantastic.
This is the first time in history that we've had so many people survive to such a long age. It's been said that the benefits of the 20th century were that we have a prolonged lifespan. The challenges of the 21st century are to make sure that we have a quality of life for that lifespan, and that is a big challenge.
Such a big challenge has propelled a movement called Age-Friendly Health Systems, a national effort to incorporate geriatric practices throughout healthcare using the 4 M's. Matters of importance to older patients, medication only as needed, mobility daily to ensure function, mentation to prevent and manage dementia, depression, and delirium. 4 goals that seem simple but represent a culture shift in medicine.
It's very unlike a cut and dry, follow the rules sort of a system. We really have to weigh a lot of factors in making decisions. The person's kidney function, which is the way most medications are gotten rid of in the body, tends to slow down with time. And so we have to carefully adjust medications to be sure that there aren't unintended side effects. Persons that are sick and elderly also experience a state of what we call delirium. Geriatrics is actually a very collaborative specialty. We talk to families, we talk to patients to the point that the patient can participate. Ms. Hatcher, good morning.
But it takes convincing for some patients who are turned off by semantics.
They come in, they say we're the geriatric doctors, and I'm saying, what? What do I need with a geriatric doctor? And to wake up. And I'm 68 years old, and I know that I'm older than a lot of people. You know, give me a break. We've worked hard to get this old, and we would like some more special words for special people. I don't like the word elderly.
Sandra Hatcher admits her pride almost cost her the kind of medical care she has come to value and embrace. Hatcher is diabetic and gets periodic infections in her foot.
I think with any doctor, you want them to specialize in what is wrong with you. And I want them to have patience and kindness to help me with whatever my needs are, which are going to be different than if you have children in here or teenagers or even just middle-aged people.
So what are some things that you all got to see this morning?
The demand for geriatric trained doctors and nurses is strong and growing, but the supply is not. According to the American Geriatric Society, there are more than 7,300 certified geriatricians practicing in the U.S., a fraction of what will be needed by 2030. Geriatric training programs across the country offer attractive fellowships to future medical professionals, but half the spots go unfilled each year.
We have seen programs to help support geriatrics education decline in terms of funding. We've seen participants in our application pool decline, yet the ideas are still alive. We're seeing others adopt them, and I think that that is probably the future.
My name is Dr. Melanie Morris. I'm a colorectal surgeon here at the University of Alabama at Birmingham. All of us as surgeons, we want to be taking the best care of our older adult patients that we can be. We just aren't trained in the geriatric principles.
Dr. Morris and colleagues at the University of Alabama, Birmingham are part of a pilot program testing how best to inject geriatric standards into surgical procedures. UAB is one of 8 hospitals nationwide chosen by the American College of Surgeons for the Coalition for Quality in Geriatric Surgery project. Among the goals are to reduce postoperative delirium, which occurs in half of older patients, functional decline, and readmission to the hospital, which happens in about 15% of patients 65 and older.
I operated on an 86-year-old patient 2 weeks ago. We had our geriatrician team involved as well as our pain service team to help us treat her pain in a way that would both help keep her comfortable but also not induce more delirium or worsen her dementia. And she was able to go back home with her husband in better condition than she came here in.
There's not going to be enough geriatricians to care for every older adult in the United States. So if you're a nurse or a social worker or a cardiologist or an oncologist, you're going to be taking care of older adults. So let's give those folks the knowledge and the tools to deliver geriatric-friendly care. And let's also have geriatricians work with health system leadership to change health systems.
UAB is a leader in expanding geriatric-friendly care throughout its huge healthcare system, the 3rd largest public hospital in the country. This ambitious effort is rooted in UAB's unique approach to caring for older patients, using a model known as ACE, Acute Care of the Elderly.
I know you got a new consult this morning. My name's Terry Middlebrooks, and I'm the ACE Unit Coordinator. You're standing right at the Nurses Hub, and this is centrally located, and it's a great location for this nursing station because we have visual access to all of our different hallways. They're 65 and older. They might be frail. They might have some geriatric issues. We understand function and cognition is very important. We understand that the family is important as well. All right, I'm fixing to go see some people down here on this hall. Okay. So we're going to go see Miss Fansler. She's 99 years old. And she's really pretty independent for 99. There's a gel in and gel out before you go in every room. Hey, Miss Fansler.
As coordinator, Middlebrooks must know every patient's goals, status, and interactions with medical team members. And the team concept is a distinguishing feature of the ACE unit.
I thought that was a cool thing to work on.
So you have doctors, nurses, pharmacists, social workers, dietitians. There wasn't a structure that allowed all those team members to all develop the care plan for a patient all at the same time. So the ACE model transitioned hospital units from multidisciplinary to interdisciplinary. And you put them around the table all together every single day.
She does not have baseline cognitive impairment, but she was altered on admission.
It's like a football huddle. And that's a little bit like what an ACE team is like. It's a daily huddle with a structure and a common language to develop the individual care plan for that individual patient.
She will likely need rehab.
Interdisciplinary care has been a key feature of ACE units since the first one was created in 1994 at Cleveland Medical Center, the brainchild of Dr. Landefeld.
This is a photograph of the first ACE unit. In the late 1980s, we had an opportunity to think about the question, how would you redesign hospital care so that older people would be able to go home better able to walk and talk than they often were.
Dr. Landefeld's team began to re-examine some hospital practices that were commonly used with older patients 30 years ago.
You think about what happens to an older person who comes in the emergency room. The first thing we do is we strip them. If they start acting weird, we'll tie them down, or we'll give them medicines, or at least in those days we tie them down. You're not going to get a good night's sleep, so they get sleep deprived and may get delirious as well. We're interested in these things called tethers that tie people into their beds, the IV, the urinary catheter. We wanted to change the physical environment and how people cared for folks to try and allow and promote people to get better.
Landefeld's approach included design of the unit to better accommodate older adults, interdisciplinary care using a collaborative team approach, medication review, limiting unnecessary drugs, reducing physical restraints, allowing nurse-initiated interventions, early planning for discharge, and patient and family involvement in care decisions.
More people were able to care for themselves when they left the hospital. Fewer people went to nursing homes. The patients and the families were more satisfied with care, and the doctors and nurses were also more satisfied with care.
A school teacher.
A school teacher.
Fast forward a couple of decades, and ACE practices have been embraced by more than 200 hospitals in caring for older patients.
Well, I'm tickled to see you up in that chair. That's the best thing for you. One of those things we try to do is keep them moving, keep them just like they were at home.
Now let's start walking towards the doorway. Let's see. Like having an IV or having a catheter, and sometimes people get afraid to move, and so they stay in bed longer, which makes you a little weaker. So we're trying to explain to her, we need to get you up moving to maintain the strength that you have. Very good. Or the family might say something like, this person is not ready to get up here because they're maybe confused, and we say, well, there's a name for it, it's delirium. Let's try and prevent it. So then we'll teach them how to prevent it.
Step by step, ACE is going viral at UAB.
I see a dramatic difference between now and 10 years ago at UAB Hospital. I now meet a workforce who can tell me all the things they did to not use a restraint. I meet a workforce who knows what Beers medications are. Those are medications that may be inappropriate for older adults. That was not happening 10 years ago. And I see a workforce that is now giving geriatric lectures to their peers.
You ready for some music?
Heck yeah.
Now you told me so you like country western, right?
Yep, I do. The old stuff. I don't know anything about the new stuff.
Okay, I got you. Hey, good looking. There you go. What you got cooking? How's about cooking something up with me?
When microsystem by microsystem, you're hardwiring geriatric care processes, and that's being driven by champions at the local level, that's how you change an entire large academic medical center.
I got a hot rod board and a $2 bill.
We are in the process of turning every unit into this ACE-like unit.
I'll get kissy bye.
What began as an effort to make sure older patients leave the hospital as well or better than they arrived has now become a model for hospital care of all patients, no matter what age. It's a culture shift that is impacting hospitals and medical professionals in many specialties.
Thank you. Thank you so much. All right.
Well, good morning.
Good morning, Dr. Shell.
How you feeling? I think she's doing very well. She's pretty much right on track, maybe a little bit ahead of most people. And back in the days before you could replace hips and knees, people became invalids. So if you can keep somebody active and out of the hospital and keep them functioning, I think it's a very good investment for society, not just for the individual alone, but for society.
I can't complain at all.
Good.
You know, usually with a hospital experience, you've got a lot of negative stuff going on. But I cannot say that. I cannot say that. I have had excellent care.
Good to
Thank
see
you, sir, very
All right,
much.
Good.
But a key part of Busick's successful medical prognosis has to do with her preparation and engagement as a consumer of healthcare.
Bye, thank you.
New tests, new medicines may not always be the best, so question the provider. Does my mother really need another medication? Ask, how is this going to help me? And are there any alternatives?
We're always going to need a hospital for the intensive care unit. We're always going to need a hospital for the operating room for heart surgery or something like that. But for many things, can we provide some of this care in the home in ways that will prevent more of the complications of hospitalization and that will keep people where they want to be?
I want to have a full life, and that's what I want. If I'm going to be here, I want to have a full life.
I think she intends to be here for quite a few years yet. This will give her the opportunity to have a full life and be able to walk.
Poor Janet.
Medical providers are constantly discovering new technology, drugs, and treatments to heal and prolong life in the hospital. As we age, it's important to talk about how to use hospital care in a way that's best for your condition. The goal is to reduce the risk of harm during your stay and allow you to advocate for care that considers your age and health status. To learn more about Aging Matters, visit our website at wnpt.org/agingmatters.
Major funding for NPT Reports Aging Matters is provided by the West End Home Foundation, enriching the lives of older adults through grant-making, advocacy, and community collaboration. The HCA Foundation, on behalf of TriStar Health. The Jeanette Travis Foundation, dedicated to improving the health and well-being of the Middle Tennessee community. Cigna Health Spring. Additional funding provided by Jackson National Life Insurance Company, the Community Foundation of Middle Tennessee, and by members of NPT. Thank you.